A 28-year-old female with a history of Hodgkin's lymphoma treated with mantle radiation therapy presents with a dry cough and progressive shortness of breath. Her treatment was completed 2 months ago. I am showing you her posteroanterior chest radiograph. Describe the findings.
The chest radiograph demonstrates bilateral, symmetric, paramediastinal airspace consolidations containing air bronchograms. The most striking feature of these consolidations is their sharp, straight, geographic outer borders that do not correspond to any lobar or segmental anatomical boundaries. Instead, this geometric pattern conforms exactly to the shape of a classic mantle radiation portal. These findings indicate acute radiation pneumonitis.
At what time point following the completion of thoracic radiation therapy does radiation pneumonitis typically become visible on radiographs? And how does it differ from chronic radiation fibrosis?
Radiation pneumonitis typically becomes visible on chest radiographs 6 to 8 weeks following the completion of radiation therapy, although chest computed tomography can detect subtle ground glass changes earlier. In contrast, radiation fibrosis represents the chronic phase of injury, which typically develops 6 to 12 months after treatment. Fibrosis is characterized by dense, linear opacities, volume loss, and traction bronchiectasis.
What is the term for dilated bronchi within fibrotic lung tissue? And how do you differentiate radiation-induced changes from infectious pneumonia or tumor recurrence?
The term is traction bronchiectasis, which is caused by the mechanical pulling of surrounding fibrous tissue on the bronchial walls. Differentiating radiation pneumonitis from infection or tumor recurrence relies on 2 key factors. First, the strict matching of the opacity to the radiation treatment field margins, and second, the characteristic timeline. Infectious consolidations or tumor recurrence do not respect the geometric borders of the radiation port and usually follow pulmonary lobar boundaries. Symptomatic pneumonitis is treated with systemic corticosteroids. I would recommend referring the patient to radiation oncology and starting a trial of oral prednisone.